So basically, I'll talk about endovascular cerebrovascular disorders. I know this is something that you guys probably don't see very much of, so I'll try and focus on three things that you might actually see. So let's see if this works. I have no disclosures. So this first patient is a 46-year-old healthy woman who suddenly got the worst headache of her life. Showed up in the ER with this headache. She was non-focal but very lethargic. And so the CT scan here shows, let's see if I can make this work. Well, I don't know. Basically, the one on the left shows a CT with a classic subarachnoid hemorrhage, and the right is a CT angiogram demonstrating a basilar aneurysm. Let's see if I can make this point. How does a pointer work? Exactly. There we go. So this is the basilar artery, and that right there is a ruptured basilar aneurysm. So now typically with aneurysms that rupture, they bleed and then they stop. If they don't stop bleeding, the people die instantly within a matter of minutes. So about 10% of ruptured aneurysms, the patients die instantly. 90% of them will live long enough to make it to the hospital. But even despite medical treatment, about 50 to 60% will ultimately end up dead or permanently disabled. So this is a 3D spin of a cerebral angiogram demonstrating this basilar aneurysm. So here's the vertebral arteries, this is the basilar artery, and there is the aneurysm. So now this is a lateral view demonstrating vertebral basilar, and there's the basilar aneurysm. And then an anterior view, again demonstrating the vertebral arteries, basilar aneurysm. So the way that we tend to treat these nowadays is all endovascularly. So we thread a microcatheter up all the way from the femoral artery all the way up into the head, and we pack it with these little tiny platinum coils, which you see right there, which fill up the aneurysm. The whole aneurysm clots off right away, which prevents more blood from getting into it so it can't rupture again. And then what happens is it turns into just a mass of scar tissue and platinum over time that typically won't ever regrow or rebleed. And this is obviously a much less morbid way of treating patients than doing an open craniotomy. So cerebral aneurysms are generally congenital lesions, meaning the vast majority of people who have them were probably born with them, so they may have started small and they can grow with life. It's actually very, very rare for someone to develop an aneurysm from scratch when they didn't have one. The overall incidence is somewhere between 2 and 5% of the population will actually have an aneurysm. However, if you have one, the rupture rate is actually pretty low. It's typically less than 2% per year overall. Things that increase the risk of rupture are cigarette smoking, hypertension, and drug use, specifically cocaine and methamphetamine. But other things, exercise, head trauma, stress, all the other kinds of things that people worry might make them rupture, do not increase the risk of rupture whatsoever. The risk of rupture is related to the size of the aneurysm. The bigger they get, the more likely they are to rupture. Typically, in an incidentally discovered aneurysm, we don't really worry about them much at all until they start getting to be about 5 or 6 millimeters in size. Any less than that, and the rate of rupture goes way down. Likewise, the older the patient, the lower the risk of rupture. There are some vagaries to this. A very irregularly shaped aneurysm may be more likely to rupture. Certain locations are more likely to rupture. Other locations, there's no chance of rupture. So you get aneurysms in what's called the cavernous segment of the carotid artery behind the eye. There is zero risk of rupture of those, so we don't worry about them. So I end up seeing a lot of incidentally discovered aneurysms, most of which only need to be followed, or some of them are so small they don't even really need to be followed. We find a lot of these incidentally nowadays, typically in older people who come in, either they have a head bump or they have a TIA, they get a CT angio, they find an incidentally discovered aneurysm. The vast majority of those don't ever need to be treated. So generally speaking, we recommend treating unruptured aneurysms greater than 5 to 6 millimeters in size in patients younger than 70. There aren't necessarily hard and fast recommendations in this, but that's the general indication. Ruptured aneurysms, though, are a different deal. So when an aneurysm comes in ruptured, generally speaking, as long as the patient is still alive, you do want to treat them. Treating aneurysms is something which we typically try and do within the first 24 to 48 hours. It doesn't necessarily have to be done immediately, like a stroke, because, like I said, the aneurysm bleeds and then it stops bleeding, and then they come into the hospital. However, there is a high risk of rebleeding over the first 2 weeks. So typically we want to get it treated so it doesn't rebleed, because if it does rebleed and they survive the first bleed, they probably will not survive the second. So that's why we usually treat it within about the first 24 hours. Now here's a fundamentally different kind of presentation of an aneurysm. This is one of the rare aneurysms that presents without rupturing. So this is a 64-year-old woman who presented with a partial sixth nerve palsy on the right and a gradual onset of a headache. So not this spontaneous onset of the worst headache of her life. And otherwise, her exam was completely non-focal. So she underwent an MRI and a CTA, which demonstrated a giant cavernous sinus aneurysm. And then she was treated with embolization with something called a pipeline embolic device, which is, as opposed to those coils, which I showed you before, that you pack inside the aneurysm, this is basically a stent, but an extremely tightly woven stent. It's so tightly woven it can actually, while it's not quite watertight, it can dramatically reduce flow across it. So here is a 3D spin. This is her right carotid. That giant thing right there is the aneurysm. Now, I don't know how many of you remember your neuroanatomy, but these typically, while they don't rupture because they're entirely encased in the cavernous sinus, they get so big they compress the cranial nerves going through the cavernous sinus to the eye and cause gaze difficulties. So this is the pre-op imaging. This is preoperatively an AP, like looking at you from the front carotid. So the right carotid, you can see how much stasis of flow is in this. And this is a view of the same thing looking at them from the side. The interesting thing about these is they get so big, they almost have a sump effect. You can see how there's almost sluggish flow up in her head because so much blood is just getting caught up and pooling in this. Now here is a still image of the pipeline device. So here's a microcatheter I've threaded all the way up into here. And this right here, you can see this stent going through the carotid. The problem with these lesions that makes them difficult to treat is not only is there this giant aneurysm, basically the carotid comes in one side and then it comes out the other. And trying to get a wire from one to the other to put the two together is like finding a needle in a haystack. So you're up there fishing around for ages, trying to get a wire across it and then a microcatheter, and you span the entire thing with this stent, which then diverts flow away. And so this is an angiogram right after deploying this. So all this you see here is stasis in contrast. So already it's blocking flow in here. And then this is a view from the front. You can see all this contrast just pooling in it already, and then the flow going through here. And so these patients, this is just an overnight procedure. They go home the next day. We typically put them on Plavix for 6 months and aspirin. And this is what the angiogram looks like 6 months later, with a completely recanalized carotid compared to what it looked like beforehand. With these devices, not only do they block flow and then the thing thromboses off, but they're so tightly woven, they basically provide a scaffolding for new endothelium to grow on. So basically you grow an entirely new carotid endothelium over this stent. So you've got basically seamless carotid going now from there to there, whereas before you had this giant aneurysm. And then the aneurysm itself, once it thromboses off with these, it will actually shrink and go away completely. So a follow-up MR of these will show the aneurysm is totally gone. So this is a big technological improvement for aneurysms, which historically were sort of a nightmare to deal with, where you would have to do an open craniotomy, you would do a bypass, from the superficial temporal to the MCA, or do a carotid to MCA bypass, and then sacrifice the carotid artery. Big morbid operations, a lot of risk, down to what is essentially day surgery. People go home and they're absolutely fine with minimal recovery. So next, carotid stenosis. This is something which I'm sure some of you guys see. So general indications for treatment are asymptomatic carotid stenoses greater than 70% narrowing we typically treat, and symptomatic greater than 60%. Generally speaking, we're talking about patients less than 80. Over 80, the data to support asymptomatic treatment of asymptomatic carotids is pretty soft. It's pretty rare that we need to treat someone over that age. So they can be treated by either a carotid endarterectomy, open surgical treatment, or now by a carotid angioplasty and stent. So stenting, even though it's now been around for a couple of decades, it is still currently reserved for patients who are considered high surgical risk patients. So the most common indications for that are contralateral occlusion. So one side's tight, the other side is totally occluded. Those are higher risk for open surgery. Recurrent stenosis, so they've already had a carotid endarterectomy, now it's re-narrowed from scar tissue, another great indication for stenting. Radiation-induced stenosis, so people who have had, say, laryngeal cancer, they've had a radical neck dissection and then had radiation therapy to it, those should always be treated with a stent. Surgically inaccessible lesion, meaning it's way up under the jaw, so you just can't get to it, or it's way down low, so you can't really get to it without cracking the chest. You're better off just stenting it. And severe medical comorbidities. There's some other sort of less common indications. So, for example, patients who are going to have a coronary artery bypass and they have a high-grade carotid stenosis, even if it's asymptomatic, those patients have a very high perioperative stroke rate during their CABG. So we'll routinely stent those carotids the day before, and then they'll go ahead and have their CABG. So here's an example of radiation-induced stenosis. So you see this very tight, narrow lesion here that was right in the plane of where this person was radiated. So rather than a plaque, it's all just extremely narrow from scar tissue. And this is after angioplasty and stent. Here's sort of dynamic pictures. So before, so this is the internal carotid and the external carotid and the common, and this is after. So there you can see the outline of the stent right there. And it's now completely reopened. Up here you have a little catheter spasm from what's called the distal protection device. So when we do these, we, again, go in the femoral artery, thread a sheath up to here, put a distal protection device, which looks like a little filter, like a windsock, up past the stenosis to catch any debris, then put up a stent and deploy it, and then an angioplasty, and then you take the filter out. So again, a very quick in and out procedure. These patients are typically placed on Plavix for a month. These stents are non-drug-eluting as opposed to coronary stents, so they don't need 6 to 12 months of Plavix. They're very large, so they don't really need to have drug-eluting stents. Actually, the risk of restenosis from carotid stents is very low. It's probably lower even than it is for carotid endarterectomies. So, and then typically what I will do is follow them with ultrasounds annually for a couple of years afterwards, and then biannually for the rest of their lives, just to make sure they don't develop recurrent stenosis. So acute stroke, this is something where interventional technologies have dramatically changed the management of stroke. So as most of you guys are aware, the first big change in management of acute stroke came when IV TPA therapy was approved. So IV TPA, or the clot-busting medicine, is typically given for patients who have strokes within 3 hours, and now there's what's called the extended window up to 4.5 hours out. So if you're within 4.5 hours out of the onset of your symptoms, you can get intravenous TPA for your stroke. The problem is that, A lot of people obviously are not found and got into the hospital within that 4.5 window. The other thing is a lot of people just wake up with a stroke in the morning. You have no idea what the time of onset is. Last but not least, IV TPA does not tend to work for what are called large vessel occlusions. So if you block one of the really big blood vessels in your brain, IV TPA typically cannot reopen that. And then again, even 4.5 hours is a very, very narrow window for someone to get found, to the hospital, diagnosed, and getting treated. So you're weeding a lot of people out. So mechanical thrombectomy for strokes, where you physically go up, again, with a microcatheter, and nowadays we use a device or a category of devices called stent retrievers, which are essentially stents on a wire that go up and deploy into the clot, smush it to the side, immediately restore flow to the head. You leave it deployed for about 5 minutes, and then you literally just pull the whole stent out, and it pulls the clot with it and restores flow in there. So generally speaking, the window for treatment with these is about 8 to 10 hours, but this is very much in evolution. There's a lot of research going on using something called CT perfusion right now, which can tell us how much brain is alive and how much brain is dead in a stroke patient. And what we're finding is that the window can vary enormously in people. Some people come in early and the brain is already infarcted and it's too late to do anything. Other people can come in 24 hours later and still have viable brain, and it's worth going ahead and doing a stroke intervention, and they may get dramatically better. So the window historically has been pushed out to 24 hours for posterior circulation, meaning vertebrobasilar strokes. That part of the brain is both a lot more resistant to ischemia, and also the stakes are so high there. Basically, these people are going to end up dead or locked in with this stroke, so you're better off just being aggressive with them because there's almost no chance of meaningful survival for them. And it can be performed in conjunction with IV TPA. Even if someone comes in within 3 hours and they get IV TPA, they can, if they've got a major vessel infarct, you just rush them straight to the cath lab, even if the IV TPA is still going. And so here's an example of an 80-year-old woman who came in, who was found down at home, unknown how long she was down, was severely lethargic, barely able to be aroused when she was found, deteriorated rapidly, and so on arrival to the hospital was obtunded with some abnormal eye reflexes, but basically it was unresponsive, and was found to have a basilar occlusion. So this is her vertebral artery right here, looking at her from the front, and the basilar, and you see this stump right there. And this is a view of the same thing from the side. So the vertebral artery coming up here and this big stump. So even though we weren't sure what the time of onset was, because of the severity of this, we took her straight to the cath lab and threaded a microcatheter up, deployed the solitary device, pulled it out, pulled a big chunk of thrombus right out from her vessel, and in one pass got restored flow of everything here. And despite her age, which is definitely on the upper end of people that we typically intervene on, she woke right up afterwards and ended up with just a partial field cut to the left and a little bit of very minimal diplopia, but it was otherwise completely neurologically intact. And she ended up going home after this. So, in conclusion, basically neurointerventional techniques allow treatment of difficult or previously untreatable pathologies with much lower risk and much better outcomes. And this is very much a technology-driven field. It's driven by new devices and things like that, so that as new and better devices come out, the indications of what we can treat grow and get better, and this is going to steadily displace more traditional surgical techniques. The end.